Hello there. My name is Dr. Benjamin Galen, and I am the editor-in-chief of POCUS Journal. It brings me great pleasure to be recording the 12th episode of the POCUS Journal podcast, which is available on many podcast platforms as well as at our website, pocusjournal.com. But my excitement today has to do with the topic and our guest. Our guest is Paul H. Mayo, a man who, for many listeners, needs no introduction. But in a second, I'll let him introduce himself. And we're going to be talking about his research from the November issue of POCUS Journal, which is on page 30 of the latest issue from November 2025, volume 10, the second issue. And their research article is entitled Measurement of Systolic Blood Pressure Using POCUS with Color Doppler Compared to an Intraarterial Line. So, without further ado, Dr. Mayo, tell us about yourself.
My name is Dr. Paul H. Mayo. H is for Henry. And I thank Dr. Galen for inviting me for this podcast. This is probably the first podcast I've ever done related to POCUS. Um, and like Dr. Galen, I'm a professor of clinical medicine. Dr. Galen is also a professor of clinical medicine at Albert Einstein Medical College. I work over at Northwell Health, which is a large system within the New York City area, and I do full-time ICU work still at Long Island Jewish Medical Center and North Shore Hospital. Those are the tertiaries for I think it's a 36 hospital system. Um, Sadly, I'm a PGY 47, so I've been in the business for a long, long time. I'm still team leader in active ICUs on a regular basis. Dr. Galen asked me to give a little snippet about how I got involved with POCUS. And this was in 1995. I was hanging around, I was over at Old Beth Israel as unit director. I was hanging around, feeling pretty good, feeling I was at top of the world, I was a critical care guy. And coming out of, it was bed 16, a guy named Bent Herwig, German. He had trained in Germany a couple of years and came over to train in the United States. And he was rather one of these stern guys. He comes out and he was said very in this German authority voice, "Where is the ultrasound machine?" And I'm looking at it, I'm saying to myself, this guy is like a little crazy, maybe. He's asking for an ultrasound machine. Well, so I said, well, what do you mean? He said, is that it over there? And he was shaking an EKG machine, literally. Is this it? He was very, and I said, what are you talking about? He said, well, this person has new onset renal failure. We have to do an ultrasound on him right away. And I'm like saying, huh? Literally, huh? And he said, he may have hydronephrosis. We have to save the kidney. So, you know, I fell into conversation with him when I informed him that we didn't have an ultrasound machine. And he said, that's shocking. I was fully trained in ultrasonography in Germany, 3 years of residency. I had to perform 400 body ultrasounds to be DEGUM certified. I won't try to tell you what that is, but it's the big society over there. And I started thinking about this, saying, well, yeah, he says, yeah, we just do it, especially we focus on abdominal for your internal medicine. So I spoke to my chairman, Mark Rosen, a great guy, best boss I ever had. And he said, well, maybe you ought to get an ultrasound machine because he always thought out of the box. He said this, he says, never heard of this, but hey, sort of makes sense. And through some shenanigan, he knew how to fly under the radar. We got ourselves a crummy little ultrasound machine. It was like the worst one in the United States, but it had an image. And then I spoke to the German intern, and also there was another guy. He's George Lecoutrier, came from Alsace-Lorraine, but he was German. And I found out that Japanese graduates were all really good at ultrasonography. So I didn't know how to use the machine. I didn't know anything about it. So I said, hey, can you guys train me? So I was actually trained by two German guys. and two Japanese guys who were very, very, very proficient because it had been baked into their culture during training. We went from there, and initially they were abdominal guys. We used to look and we saw this thing beating, and that's the heart. We couldn't go there, but focus on that. And then I started reading about Liechtenstein. Everyone knows who he is. And Mark Rosen, being a smart guy, said, "Why don't you invite him here for a week?" So sure enough, he shows up and he insists on using his special Hitachi machine, and he introduced us to lung ultrasonography. So that's how I got started. Just by a fluke, hearing this what I thought crazy guy demanding an ultrasound machine.
That's
That's the
amazing.
beginning.
Incredible. I love this story. I'm so glad we have that on the podcast here. Of course, I'm thinking to myself, did the patient have hydronephrosis in the end?
No, but that raises the issue that there's always complaints. You did an ultrasound, a POCUS study, and it was normal. Why'd you do it? Normal is just as helpful as abnormal when you're looking for a person who has a problem. So I reject that completely. Sort of like a patient who's in a grave shock state. You check the hemoglobin, it's 12. Why'd you check it? It's like normal range. So great, it's normal. So the fact that it was normal made me even more convinced that this was really, really useful. We didn't have to order an ultrasound that was going to be delayed by 24 hours, right? So
Absolutely.
yeah, you and I are on the same page about this. Yeah.
100%. Well, I'm thinking 30 years later, 1995 now it's 2025. Here we are, and you identified with a group there, your colleagues, collaborators, a gap in the literature or a gap in our technique. And I'm so excited about this paper on page 30 from the volume 10 November issue of POCUS Journal. The measurement of systolic blood pressure using Doppler. And I'm curious if you can tell our audience is not all ICU folks. What was the gap in the literature that you felt it was necessary to sort of design and implement, a study of this caliber, and what problems were you trying to solve?
So could we go back a little further than that,
Absolutely.
which is why on earth did I choose to study this rather small part of POCUS that might have some utility? Could I get into that a little bit?
Absolutely.
And the reason is that I'm hoping that there are some residents and fellows or watching this podcast, maybe one or two or maybe more. And one of my assignments at work is to encourage, and I hate to use require, but encourage my fellows and sometimes residents do research projects. And the key thing for those residents and fellows who are clinicians, not basic researchers, that's a different type of person, is I'm advising you always to choose a really simple project. Don't make it complicated. And the best, simplest projects are POCUS projects because they're intrinsically interesting, but also there's always a niche, some little aspect of the field that's interesting. So I said to Dan Ying, who started it, he was a second year fellow. Let's think of something. And for a couple of years, we had been done. I think what a lot of POCUS people do is you do stuff because you sort of think it works, but it's completely not validated. It attracts people the field attracts people who are thinking a little bit out of the box. And we said, can we come up with something that we've been doing and maybe we ought to validate it? So for a couple of years, we'd been greatly bothered by patients that we wanted to transfer out of the ICU, but their blood pressures were too low. They were hung up on a little bit of pressor. We're not allowed to use pressors on the floors, unlike Montefiore. Okay, thank you. You work in a real hospital, dude. So, um, uh, I became suspicious that sometimes the oscillometric techniques you have an art line in, but you're trying to avoid using those if you can, might be underestimating this, particularly in patients who had atherosclerotic disease and maybe they were overweight. So we would try to validate the oscillometric systolic pressure with color. And If we found that the color was much higher than oscillometric, we would say that's going to be our standard. That's the gold standard. Send the patient out of the unit and warn the team your standard technique will tend to underestimate this. So we've been doing that for a few years, and then we started to doing it in these hot RRTs. So I said to Dan, I said, this is the type of study that you can do, that you can actually finish it, right? Because it's not that complicated. So I'll encourage all residents and fellows who want to get started getting some CV stuff going is look for a small ultrasound project like this, and you'll actually be able to finish it. So step one is we go to IRB and they go crazy. You mean you're going to inflate a blood pressure cuff on a patient's arm? Well, that's experimental. I was like, I think it took 4 goes with the IRB. I appreciate that because they need to rein us enthusiasts in. So it took him a year to get IRB approval for
Wow.
this. And then finally he gets it, and he ran about 20, 25 patients. And then guess what? He graduates. So he turns it over to Dr. Mayo Malaski, who finished the other. And we had someone to help us with data analysis and stuff. And then the statistics, I don't know if we want to get into them, but for all the junior people here, this is really simple. You have two variables, and you can think of all sorts of POCUS things to do, right? With two variables, one of which is ultrasound, and the other is some other measurement that's validated. And then you want to correlate them. That's called the Pearson's correlation. But you also want to examine agreement between them, which is the Bland-Altman. And these are simple to do. So all of a sudden, you have two measurements and you have simple statistical analyses, correlation and agreement. And as a warning, never use ChatGPT to do your statistics ever, because it will hallucinate and it generally makes them better than they actually are. A word of caution. So remember that. All right. So then we set to work, and you can imagine the setup is simple. We would have an arterial line in, and then we'd have a blood pressure cuff, and we would inflate the blood pressure cuff while we were looking for color flow signal from the brachial artery. And one person would be looking at the cuff, the sphygmomanometer. We actually had to use a real sphygmomanometer. You
Where'd you
can't,
find one? They're hard to find.
they're really hard to find. Yeah, it was in some back room, but we calibrated, it was all accurate. And then came the major challenge. How do you zero the arterial line? Another time in another place, Dr. Galen, we can talk about using echocardiography to identify the true phlebostatic axis.
Interesting. Well, for the listeners who are
Yeah.
thinking about this technique, they're reading the paper, they want to do it. I know it's very well described in the paper, but any tips about how to get, the Doppler signal at the brachial? You're using the linear probe, of course. You optimize your visualization in B mode before you try Doppler. You have a tilt angle. Are you using
Yeah.
your transverse?
So
How's it going?
we were a little lazy, and I think in the discussion, the guys had to sort of apologize for this, that there are, many types of Doppler: pulse wave, continuous wave, color Doppler, and there's something called color power Doppler, right? It's yeah, something, yeah. And the weakness of standard Doppler, of course, is that the inclination angle has to be oriented towards in the axis of the flow of the red blood cells. And if you think about it, when you're insunating and brachial artery, you generally look at it pretty much perpendicular to flow, so you can angle it to try to pick it up. And then if you're using standard color Doppler, then you'll want to drop the scale. So the aliasing point is much lower in all those 64 tiny microscopic pulse wave Doppler sample volumes that are hiding in the color sample volume. So we chose to use something called color power Doppler, which it's sort of hard to explain the physics of that, but basically it takes the directionality out of the detector, and it gives you a very clean signal. But we also use the standard color pretty effectively by dropping the scale. Unfortunately, the machines that are used out on the floors a lot of the times, the UPUMs, ultra portable ultrasound machine.
We need a new acronym. That's right. Great.
Yeah, the
Yeah.
UPUMs, some of them don't have color power Dopplers, so keep that in mind. So then you just find the vessel and you pick up a signal either by angling and dropping the scale or turning on color power Doppler, and you watch it. And as you inflate the cuff, then all of a sudden it disappears. And then as you deflate the cuff, nice and slowly, okay, you don't want to do it too fast, your friend is looking at the sphygmomanometer and the observer calls out color or now, something like that, whatever. And then the other guy or the other gal is saying, oh, 105 is systolic pressure, right?
Perfect.
So it's pretty straightforward. And if you look at the article, the correlation coefficient is excellent. The Bland-Altman analysis, the bias is quite acceptable. But even there were, I think, a few where the color method underestimated the oscillometric measurement, which is good because you don't want an overestimate of blood pressure, right?
That makes sense.
So, but in general, it works pretty well. Now, the question is, when on earth would you use this, right? And Dr. Galen, you've been involved with many RRTs because you're like the floor guy over there. Like you're a real doctor, right?
That's right. That's right.
Yeah.
Yes.
And you rush into these rooms, and half the time the patient was asleep and they're fine, right? But then every once in a while, one of them is really, really sick, and immediately a team floods into the room, and the med students are all lined, all 20 of them along the wall, just watching. And then you have a melee of people surrounding, fighting, to get to the bedside, etc. The airway is under consideration. They're hypo, and what's the blood pressure? Because that's a key variable in a hot situation. Do they have a blood pressure? Right? And then what is it? You got to know because if it's low, you got to do something about it right away. Okay. Just like saturation, if saturation is 50%, you got to do something about that right away. Yeah. So this is where you would have occasional utility where there's some description of noise problems related to auscultation. You don't have an art line in. The oscillometric stuff is of uncertain advantage, critically ill patients. You can try it, but this is so it has limited application to high noise situations where you have an agitated crew trying to help the patient, and nobody, the auscultation can't hear a damn thing. There's no art line. And oscillometric, the patient is very large, or you really it doesn't make sense what you're getting, right? So that's where you would apply it, and then
I
we use
agree.
it as
Yeah.
an external standard if we do not believe systolic pressure in the ICU,
Right.
that's unofficial.
It reminds me of two things. One is the saying from the House of God, the legendary text from the 1970s, is at a code, first check your own pulse. But I'm going to now say to myself, at the next code, I'm first going to check the systolic blood pressure with color Doppler using the Mayo described technique. So I'll keep that one in mind. It also reminds me of when I did EMS in the 1990s. There's a technique
Uh-huh.
to use a sphygmomanometer with 120 over palp. And over palp was to see the return of the pulse at the radio
Yeah.
artery, which is basically the same idea. So that led me to two questions for you. One is
That was through palpation, right? Yeah.
palpation, correct. This is a
Yeah.
more, probably more accurate, although
Yeah.
there was no palpation arm in your study. But
Right.
the question I have for you is, could you do it at the radial if you had to? But you're sort of further away
Yeah.
from the
Yeah. We didn't
sphygmomanometer? Yeah,
think to do that because a lot of people have radial artery lines in, right?
right.
So, but it would probably work. I'm not sure you'd want to do it in the carotid position.
Yeah. The cuff
You get
doesn't
my
fit.
drift?
The cuff doesn't
Yeah.
fit as well there.
You
Uh,
could probably do it in the popliteal as well, but radial, yeah, so it would
Smaller.
likely work.
Yeah.
And the it has limited application, but I thought it was a great little project which was
Yes.
executable. And maybe I could mention another thing, which is that your journal is a must read for anybody who really likes POCUS because a lot of your reports are sort of about a detailed application that a group like mine thinks of and has probably been using it for a long time, but let's validate it. So it's a great read for people who really like POCUS. Okay.
I couldn't agree more, and thank you for that.
Well, by the way, I was embarrassed because I had never subscribed to the journal. So I went to the journal today and now I'm a subscriber. I was a reader, but now I'm a subscriber.
Well, as you are for the podcast, I'm sure a
Yeah.
long time listener, but now first time caller. No, I appreciate your compliment to the journal. It's Amar Jory's vision to have founded the journal over 10 years ago, and we have
Yeah.
a fabulous editorial board who puts in a lot of work to review articles, and our peer review volunteers, of course, do an amazing job. And it's the community of point of care ultrasound that makes it all worthwhile, and disseminating valuable, not just case reports, but high quality research like this. I think
Yeah.
this is the type of study that our field needs, is to validation type studies for new ideas and new techniques. I had one other burning question. Those little Dopplers that the vascular surgeons and
Yeah.
OB residents walk around with. That this is not an ultrasound tool, but it's a Doppler device.
Sure.
Did it occur to you to also sort of play around with that? I don't know if you have one in the unit to check
Yeah, I've
cells.
seen those around for years.
Yeah.
The vascular surgeons, also nurses have gone. I don't see nurses doing them much now, but in the 80s and 90s they were used quite widely by the nurses. We mentioned I think in the discussion that that is another that this technique is sort of similar to that. Conceptually, you're quote listening for blood flow or looking for blood flow in the critically ill patients. So we did not compare the two techniques. I think they would be rather similar. Um, the question is, if you have a POCUS device with you, then that will generally not have, unless it's a larger machine, sound emanation like the bigger machines. But yeah, both would be the same principle. You're looking for blood flow.
Yeah,
Yeah,
absolutely. Uh, Thank you. And one question also I was thinking about in terms of patient population and applicability or generalizability. Any caveats for our listeners who might try to use this in terms of physiologies like atrial fibrillation, where there's variability, or where the pulse pressure is variable, and,
yeah,
and the systolic alone kind of
yeah.
overestimates or underestimates the blood pressure, the map.
Yeah, so in terms of AFib, you would definitely have problems with this technique because the just like the stroke volume is variable with AFib depending on the antecedent RR interval. All right, you can see if you look at any arterial wave tracing in a patient with AFib, the systolic pressure is variable, and this technique is more of a qualitative technique, and that could be a problem. So what to do? Well, in a hot clinical situation,
Mm,
probably you'd like do it and you'd say the systolic is between 120
right.
and 140, or it's between 40 and 60. So this is definitely a qualitative technique. And likewise, the identification of pulse pressure variation, which is manifest on arterial lines with systolic pressure variation, that's typically resophasic, that has deep meaning for the intensivist because there are about 6 different reasons for it, each one of which requires a completely separate treatment. So this technique would not be reliable in detecting resophasic variation of pulse pressure. Tamponade, constriction, RV failure, severe hypovolemia, flow starvation on the ventilator. or severe LV dysfunction. So if you ever see that on an arterial waveform, or you can also detect it with brachial pulse velocities quite easily, then the patient needs an echo to determine why it's happening. But this technique, I don't think would be applicable.
Right. But it would certainly, be something you'd integrate into your findings if you found on
Yeah,
cardiac POCUS that there was large
yeah.
effusion with
Uh,
tamponade. It would make it.
I would emphasize that if you were looking for pulse pressure variation, that the brachial pulse wave signal will pick that up very readily, and it's a lot easier to look for that
Hmm.
than looking for LVOT velocity patterns or mitral valve inflow patterns. Those are the standard ways, but if you're in a hurry and you see it on brachial velocity, but that's a whole, well, I just thought of something. That's a little research project for a fellow. It would be titled The Rest Phasic Variation of E-wave Velocity and LVOT Velocity Compared to Brachial Artery Velocity. Yes,
I love it. I mean, you have the title of the article, you have a journal for it, you just don't have the IRB
exactly. Yeah.
done yet. Well,
Yeah.
there's some zebras I thought of too, just for your technique here. Severe peripheral arterial disease that affected the upper arm, a thrombosis.
Yeah.
That
Yeah.
would be a limitation if you had a thrombosis there.
Yeah.
That would be
And
absolutely
then these occasional diseases with asymmetric, brachial artery velocity patterns, coac, um, uh, aneurysmal
right.
dissection and crazy stuff like
Unusual.
that.
Yeah.
So one of the things that in your most recent journal, you had a nice discussion of lung point. Okay. So, when Liechtenstein brought out lung point, it was 100% specific, right? And in recent years, it's been recognized that there are other things that can cause a lung point, a so-called pseudo lung point. And um, that's a perfect example, as are some of your questions about the article we've been talking about, that POCUS is never perfect. Okay. It's all within clinical context and everything. So, but that's one of the beauties of the field. It requires some clinical judgment. Okay. And also knowledge of that it's an imperfect technique, but conceptually it's perfect, of course. Yeah.
Well, that's you're right to point out. I agree. I think
Yeah.
and we've been discussing this in the context of emergency scenarios on the hospital floor, for instance,
Yeah.
or the ER, or sort of the in the ICU in critical settings where there are knowing the limitations of the tool are important, but having those tools in your toolkit can be very,
Right.
very helpful.
Yeah.
Um,
This would not be applicable to routine use in a ICU. That'd be silly, right? But it's sort of a circumscribed application.
Absolutely. I agree. Well, we're so grateful to have your publication in the November issue, and we're also so glad that you're able to join us on the podcast today. Everyone listening, Dr. Paul Mayo, Paul H. Mayo, it's been such a privilege. We're really glad to have your leadership and mentorship in this community. So many people listening, I'm sure, look to you as someone who's taught them many things over the years, and we're grateful to have you here today.
Could I finish with a final comment?
Absolutely. I was just
Yeah,
about to
that
ask for your final comment.
you're going to receive on a semi-irregular basis more submissions from my fellows. Okay. And I'll comment to the audience. This is a must-read journal for the interested POCUS person. It really is. Okay. So keep up the good work, my man. All
Thank you
right.
so much.
All
Paul,
right.
thank you so much. It's been a privilege.
All right. You take care.